Okay, well, thanks everybody for attending. This is really exciting. This is something we've been talking about for a while, and it is great to be able to connect. And I think at this time, when we're all separated and isolated and going through some similar and maybe some different struggles, it's nice to be able to connect with people. So I'm really excited to be starting this first Journal Club session off, and I hope it will be a very interactive session. I am recording it, so we will have a recording of this available on the ACVNU website, and I will send an email out to the ACVNU listserv about where you can find this recording, because I know certainly not everybody is able to attend due to the time constraints. People have been great so far, so just for a quick reminder, please keep your microphone muted. However, I do really wish for this to be a interactive journal club. I don't want this to be a lecture and just have me talk for a while. I probably don't even have enough stuff prepared to talk for the full hour. So it would be great if we are engaging in discussion and debate and going back and forth. And if you have something you want to say, then please just go ahead, unmute your microphone, chime in. Let's have some discussions about things. Just remember to mute when you are no longer speaking. And if you can't speak because you don't have an active microphone, then certainly if you just want to write in the chat, I'm going to be paying attention to that throughout the session as well too. So based upon the survey I sent out to the ACVNU members, people were most interested in having these rounds every other week. So that's what we're going to do. I'm very excited. I think it's a big task to take on and a lot of momentum to keep rolling, but I'm very excited about this, and hopefully people will be more and more excited to join, and this will be a regular occurrence. So our next journal club is actually scheduled for 2 weeks from today, and Dr. Ewan Wolf will be presenting. I will send the article out and give more information on the ACVNU listserv. So if you're interested in joining ACVNU, I would really encourage it. Check out our website. We're, I think, a very great community that is really friendly and supportive of one another. And the organization has a really nice listserv where we can discuss some challenging cases and things like that we're dealing with. So I encourage everybody to join the ACVNU if you're not already a member. And they're the society that's kind of putting this on, so most of the communications will be through them. So with that, let's go ahead and we'll get started with the journal club. So the article that I chose to present today is a very recent publication that came out in JDVIM by Dr. Shropshire, Johnson, and Ulver, and it's platelet aggregometry testing during aspirin or Plavix treatment and measurement of Clopidogrel metabolite concentrations in dogs with PLN. This is a study that came out of Colorado State. So again, let's have this be open, and I am very interested in hearing everybody's experience dealing with thrombosis in patients with kidney disease and PLN, nephrotic syndrome, as well as their management styles. And I think that would be a great discussion. But just backing it up to the beginning and really trying to frame why the study was designed, and kind of going from their intro materials, we do have a lot of evidence in dogs that proteinuria and protein-losing nephropathy is associated with hypercoagulability. I believe this is the first paper that was published in naturally occurring disease in dogs back in 1971. I believe this is out of Davis, showing that dogs with renal amyloidosis had a fair amount of them had thrombosis. There were a couple case reports in the early 80s, I think 1982 and 1983, of like 3 dogs here, 4 dogs there that had thromboembolic complications associated with protein-losing nephropathy. And then we started seeing some additional publications coming out, kind of review articles. These were 2 that came out in the mid-80s that discussed hypercoagulability in the nephrotic syndrome in dogs and gave some reasons for why they thought it could be occurring and maybe how we can manage it. But this is pretty early on in the way that we are approaching dealing with proteinuric diseases in dogs. And even some of these papers that had histopath, which was terrific, having things like immunofluorescence and electron microscopy were not regularly available. And so our ability to identify the type of kidney disease is so much more advanced than where we were back in the 70s and 80s, which is terrific. But it's interesting to see if some of these studies would be repeated. Maybe we'd have some different phenotypes of dogs that were being presented. So we have several articles that are describing proteinuria and PLN being hypercoagulable. But then we also have some articles that have looked at patients who have had thrombosis and thromboembolisms. And let's see how many of those patients actually had PLN as their underlying cause. So I just pulled 4 papers, and I apologize if I missed anyone's publications. I tried to do a pretty extensive lit review for this, but I'm certainly sure I could have missed something. But going back, looking at, I think the largest study we have of a retrospective evaluation of PTE in dogs, only 2 out of the 47 dogs in that study had evidence of renal disease. And 1 actually had acute kidney injury secondary to ethylene glycol toxicity, and the other had some type of PLN. When we look at portal vein thrombosis, about 1/3 of those patients had underlying kidney disease, and that was probably proteinuria kidney disease, although it wasn't super well described. When we go to the arterial side of thrombosis, looking at aortic thrombosis in dogs, there are 2 publications. The one study that came out in vet cardiology showed that about 1/3, again, 35% of dogs had PLN, but there were probably about half of those dogs that also had an endocrinopathy. Most were hypothyroid in addition. So there was a decent number of dogs that were proteinuric, but they also could have endocrinopathies that potentially could be a risk factor in its own right. And then the last article, and these are all from the 90s and actually from kind of the early 2010s, showed that of dogs with aortic thrombosis, there were only about 2/3 of them or so that had any urine testing for proteinuria, but of those who had urinalysis being tested, 95% of them, so all but 1, were actually proteinuric. And maybe that could certainly be skewed because maybe those patients were hypoalbuminemic and people were concerned, well, this dog could have PLN, let me do a urinalysis, and aha, look, I've confirmed that this patient, it does have PLN. So the retrospective analysis could potentially skew it, but clearly we're seeing dogs that are coming into the hospital with clots, whether it's in their lungs, portal vein, in their aorta, or potentially anywhere. One of the diseases we have to be worried about and we need to screen for is protein losing nephropathy. So why is that? Why are dogs with PLN hypercoagulant? And it's probably multifactorial. So one theory and one proposed mechanism, and it's been the main mechanism that's been proposed, has been the loss of antithrombin. So antithrombin 3 is a pretty small molecule. It has a pretty short half-life of only about just under 2 days in dogs. And it's a naturally occurring anticoagulant. It inhibits factors 2, 9, 10, 11, and 12, although the majority of its clinical effects occur through its inhibition of factor 10. So if we're losing an anticoagulant, then we are certainly at risk of having thrombosis. And so some studies have specifically looked at that. And if we look at our coagulation factors, so this is the canine coagulation factors, we can see that antithrombin has a size, a weight of about 68, 69 kilodaltons, and antithrombin 3 has a weight of about 65 kilodaltons. So it's very similar in size, and it's been theorized that if we are having glomerular disease and we're losing albumin, we're likely losing antithrombin because those pores are about the same, the molecules are the same size, they can fit through those pores that are there. So it's thought that altered glomerular permeability, increased permeability leads to the loss of antithrombin 3 in urine. And that's been pretty well established. This is a manuscript of just 14 dogs from the 80s that had nephrotic syndrome. And if we look at albumin, again, being 69 kilodaltons, and we look at their antithrombin concentrations, we can see that most dogs, whether they had immune-mediated nephrotic syndrome or not, had low antithrombin concentrations. But we'll come back to this in a subsequent slide. You can look at the size of these coagulation factors, and certainly some of them like factor 10, factor 7 are smaller than albumin, but those are actually shown to be in higher concentrations in dogs with nephrotic syndrome than lower. So maybe the loss of antithrombin through the urine is part of an explanation, but it doesn't make sense that we're not having loss of all similar size molecules. And it's been proposed that maybe we have increased hepatic synthesis of some of these other factors being a positive, acute phase proteins and things like that. And that very likely could be true, but it's clearly not as straightforward as just a matter of the size. Julie brings up a good point that, well, the charge could certainly be a factor, and that's very true. Some of these molecules are going to have different charges, and the more negatively charged they are, the harder they're going to have of a time passing through the GBM. However, in some types of glomerular disease, some of the main reason that we lose that permeability is the GBM loses its charge, and that we have a reduction in that negative charge of the glomerular basement membrane, and now we're having molecules that can leak through that otherwise shouldn't be able to. So that it can't be as simple as just a pore size that's there. But we have lots of evidence to support that dogs with nephrotic syndrome and PLN of various different flavors have low antithrombin 3 activities. So looking at studies that have been published, dogs with amyloidosis between 40 to 70%, depending if you're Sharp-Hayes or not, had decreased antithrombin 3 activity. And one study also showed that of dogs that were hypoalbuminemic, so if their albumin was less than 1.8, all of those dogs were also having a low serum antithrombin activity. One study actually looked at dogs that were healthy and compared that to dogs with non-proteinuric chronic kidney disease, although their inclusion and their definition of non-proteinuric CKD was a UPC less than 1. So some of those dogs would be borderline or be proteinuric. And they compared that to dogs with PLN, which had a UPC greater than 2. And they found that dogs with PLN had lower antithrombin activity compared to controls. However, so did the CKD dogs. And in fact, CKD dogs were not different than the PLN dogs in terms of their antithrombin 3 activity. And although we certainly see some dogs with CKD develop thromboembolic complications, in my experience, I don't think it's as nearly as big of a risk factor of these patients coming in with pulmonary or aortic thromboembolic complications. And that's interesting because their antithrombin activities were about the same. But there is some contrasting evidence, and we're going to get into this a little bit. So one study showed only about a quarter of dogs with proteinuria with PLN had low antithrombin activity. However, when their coagulation was assessed via thromboelastography, 90% of them were hypercoagulable. So it's possible that antithrombin 3 might not even predict when we are dealing with a hypercoagulable state. And that's actually been reported by other studies showing that antithrombin 3 doesn't correlate with hypercoagulability. So we know that it's a very frequent finding. We know that dogs with CKD that are not heavily proteinuric might have low antithrombin 3 activities. And it's probably not the only factor on dogs having hypercoagulability seen on a TEG. Now, we can certainly go into TEG in a lot greater detail and question what's the sensitivity and specificity of some of these findings, and does that equate with predicting thromboembolic complications? And as far as I'm aware, there's been just a very few studies in that, and they've failed to reliably show that TEG in dogs is associated with predicting which dogs are going to have thromboembolic complications. So maybe that's just too sensitive of a test. We don't really know. But there was one paper that showed antithrombin 3 activity had some prognostic ability to determine the likelihood of ill dogs that were hospitalized on their likelihood of surviving. And if you had an antithrombin activity less than 60, your odds ratio for dying was increased by about 9-fold. So it seems like this is an important metric. It seems like it's something that it could play a role, but it might not be the only factor. So personally, I don't measure antithrombin 3 routinely at all in my proteinuric patients. I don't necessarily use it as a way to predict which patients I need to treat with an anticoagulant or which ones I'm comfortable not treating with. And certainly I'm interested to see what other people are doing in terms of using antithrombin 3 testing. Is that something that people are routinely doing? Is it part of your workup and evaluation of your proteinuric dogs? So far it seems like a number of people are either not using it often, or if so, probably TEG or TEG, depending if you went to Penn or not, how you pronounce it, is probably how you're going to assess them. Some people are using platelet aggregometry, which I think is obviously very interesting and kind of what we're talking about today. So it doesn't seem like it's a very routine portion of how we're evaluating these patients. And certainly I've had some clients ask for it because they've Googled it, but I don't routinely do it. I don't think it is probably worth the finances going into it personally. Okay, so if maybe antithrombin 3 is not the only factor, there's other things that could be present. Why else might these dogs be hypercoagulable? Well, there could be alterations in our other hemostatic proteins. So this table is the same that we brought up before. And certainly looking at albumin, it's kind of towards the smaller size of all these molecules we have here on the right. But if you look at this study, which is a small study, but as far as I'm aware of, it's the only one that I could find in proteinuric dogs or nephrotic dogs that looked at coagulation factors. We have these dogs that obviously have low antithrombin activities, but they also have significantly induced plasminogen. Their fibrinogen concentrations are usually 3-fold higher. They have higher factor 5, 7, 8, factor 9, factor 10. All their coagulation factors that were measured were also found to be increased in size. And that's interesting because I said earlier, factors 5 and 7 are actually smaller than albumin. And many of these molecules, like if you look at the size of factor 8 being 2,000 kilodaltons in size, that's a huge molecule. Of course, you're not going to be able to reliably lose that through a glomerulus, even a very, very diseased glomerulus. So it's possible that they actually have increased number of coagulation factors that are there, which could be one risk factor for them being in a hypercoagulable state. It's probably not the only explanation because something has to trigger those coagulation factors and the coagulation cascade to begin its process, but it's there, and it seems like the coagulation system is primed and ready to go. PLN is also a disease of platelet hyperactivity, and there's a couple reasons for that. Hyperlipidemia activates platelets, and it's not exactly known why that occurs. Certainly the HDLs are thought to be anti-inflammatory and have antioxidant effects, and the LDLs and VLDLs can promote platelet activation in people. So this was a study in dogs out of Cornell looking at their lipid profiles and comparing dogs with nephrotic syndrome to CKD to controls. And both CKD and nephrotic dogs had lower HDLs, the protective lipids, and they had higher concentrations of the VLDLs, which are those that have the potential to activate platelets and cause significant adverse effects. Interestingly, the difference between the CKD dogs and the nephrotic dogs were not that different. Certainly they were a bit higher in terms of their VLDLs, but I don't think that that was a statistically significant finding. So CKD could be a risk factor in its own right. We also have the hyperfibrinogenemia, the increase in fibrinogen that's there. And fibrinogen has a direct activation of platelets as well too. And most studies that have looked at PLN dogs have shown them to have high fibrinogen concentrations compared to healthy controls. So that is another reason that these platelets are primed, they are ready to go based upon the direct activation. And that's been somewhat questioned, and the pathophysiology of that's not been completely worked out, but there have been studies that have shown that that's a big risk factor for your platelets to be overactive. And then we also have hypoalbuminemia. And so albumin binds arachidonic acid as it's released from the platelets, and it helps prevent the conversion of arachidonic acid to thromboxane. And thromboxane A2 is going to then go on and cause, it will prevent the, thromboxane activates platelets. So if we have less albumin, which normally inhibits thromboxane, we have more thromboxane that can be released. Therefore, the platelets can now be overactive. So some people argue that the hypercoagulability seen in PLN is actually more of the platelets that are doing most of the work, and they are the ones that are hyperreactive rather than it being problems within the coagulation cascade. I personally think that's probably way too simplistic. I think we probably have a combination of a number of different things, that we have we have an increased production of other coagulation factors. We have increased reactivity of our platelets. We might have activation of the immune system because this could be an immediate disease, and many things indicate our own weight, including maybe some of the medications we're going to use, like steroids and other things. So despite the fact that the exact mechanism is at hyper. And so if we're going to test for and identify those patients, we could look at antithrombin, which, as discussed, a lot of us do. There's some studies showing you can probably predict their antithrombin activity based upon their serum concentration. This year actually found in an older paper, 6, which it showed that if your albumin is less than 2, it's very predictive of having a low antithrombin activity. And a subsequent study showed that most dogs, and these specifically as dogs with amyloidosis, are you guys hearing me any better now? Is my audio coming back in? Sorry, my internet connection is, I'm blaming it on COVID. The internet connection has COVID at the moment. So sorry about that. So I'll just start this slide over. So the early studies have shown that albumin concentration correlates with the antithrombin 3 activity, and an antithrombin 3 activity that is decreased is most likely seen in dogs that have an albumin less than 2. So it's thought that in those dogs that are proteinuric with an albumin that's less than 2, those are the dogs that have a high risk of hypercoagulability. Unfortunately, it's been shown by subsequent studies that albumin does not actually correlate with antithrombin 3. So studies have shown that there can be a pretty big discrepancy, that dogs with an albumin less than 1.8, about 60% of those had decreased antithrombin 3 activity, but about 60% of dogs who had an albumin above 1.8 also had decreased antithrombin 3 activity. So I don't think anymore we can really use albumin to predict what the antithrombin 3 activity is. And stepping further, the albumin concentration didn't predict those patients that were hypercoagulable on a TEG, nor did the antithrombin 3 concentration. So we're really kind of muddling and trying to figure out, are these patients hypercoagulable or not? I think if we do want to test for that, we probably do have to run thromboelastography. And we have 3 studies that have looked at thromboelastography in dogs, and we've already mentioned the one that there was no difference in dogs that had or let's say minimally proteinuric CKD and PLN, that they were very hypercoagulable in both groups, but the PLNs were not more hypercoagulable than CKD. And then 2 subsequent studies have shown that 90 to 96% of dogs with PLN are hypercoagulable via TAG. So it seems like certainly this is something we need to worry about. And in fact, when we look at some consensus recommendations, the first one is from the IRIS recommendations for standard therapy of management of glomerular disease. They certainly recommend that some type of thromboprophylaxis be performed. They recommend aspirin. They say that Plavix might be similarly effective, but we don't have any evidence to compare them head to head. And then a more recent consensus statement from the critical care group has come forth, and they do recommend that PLN be treated with antithrombotic therapy. They didn't give a specific breakdown on when they would necessarily begin that treatment. So how do you ask a question? Do we know about the validity of the assays for antithrombin 3? I can't answer that. I don't know which assays they used. We could certainly go back and look at those papers to see what the assays were, going back to those tests from the 90s as well as those ones from more recent times to see how validated they are. But I didn't dive into that to assess their validity, but that certainly could be a very good question, whether we can trust those tests overall. So since we have evidence that our patients are hypercoagulable, even though we're not 100% sure why they might be, and we have reasons to think that they could benefit, and consensus guideline that we should prevent clots with some type of therapy, let's look at the drugs that we use. So Clopidogrel is a drug that's used very commonly, and obviously one of the 2 drugs in this study. And it's actually a prodrug, so it has no intrinsic activity in itself. It is metabolized by a P450 enzyme reaction within the liver. In people, the major one that does that is cytochrome P2C19. And it's been shown actually that a inhibitor of that enzyme is omeprazole. And in people, if you give omeprazole while you're taking clopidogrel, you actually have decreased activation of clopidogrel into the active metabolite and an increased risk of stroke. Now, there was one study looking at the effects of omeprazole in dogs that were receiving clopidogrel, and they did not show that the platelet function testing was any different. So it was thought that this is probably safe. However, they did notice an increase in some inactive metabolite concentrations that were observed. So it probably has some effect, but we don't know what enzyme actually metabolizes clopidogrel in dogs, and there certainly could be some polymorphism within that pharmacology as well too. So clopidogrel works by antagonizing the ADP receptor, and it causes platelet inhibition, and that's been shown. This is irreversible platelet inhibition, so this effect stays for the life of the platelet. And certainly the platelet function testing has been shown in dogs that it actually makes the platelets less reactive. There's less of strength to the clot that forms, that it is a decent drug to help prevent platelets from forming clots. The other one that we use is aspirin, and aspirin is also an irreversible anticoagulant, and it's going to inhibit cyclooxygenase 1, which normally would produce thromboxane. Now, its effects tend to be more variable, and so dogs are less reliably anticoagulated with aspirin than they are Plavix, and it does seem to have a dose effect, and there's quite a possibility that maybe some of these older studies were using too low of a dose at something like a half or 1 mg per kg per day. One study showed that you needed to give at least 2 mg per kg per day of aspirin in order to sustain reliable platelet inhibition with aspirin. So maybe the dose is just not appropriate in some of these older studies that are there. But I think both of these drugs are certainly used frequently for the management and prevention of clots in our PLN patients. So I just wanted to kind of get an idea, like how many people are using, what's your go-to drug? If you were to use one of these, how many people are using clopidogrel? How many people are using aspirin? And it seems like aspirin doesn't have a single fan so far. It seems like it's fairly unanimous that no one is volunteering using aspirin for it, and that seems to be pretty reasonable, and that is certainly the go-to drug in people. Even surgeons will say, I have no problem if you're taking aspirin before we go to surgery, because you're not going to have any bleeding problems, where we're probably going to have to wait a couple of days on the Plavix before we have some new platelets that are not inhibited by it. Okay, so other than Joe, who's old and uses aspirin, we seem to be now using maybe collectively more Plavix than aspirin overall. So let's look at going back to the study. So that was just a deep dive into kind of the background. The objective of this study was to assess the response to aspirin or Plavix in dogs with PLN, and they used whole blood impedance platelet aggregometry, and they looked at clopidogrel metabolite concentrations between healthy and dogs with PLN. So that is the objective of the study. This was a prospective study. They had initially planned on 10 healthy dogs to be enrolled. Like many studies, they were only unable to enroll 6 due to financial limitations. And the article quotes that 6 dogs were deemed an acceptable number to determine the overall response to Plavix when given to healthy dogs. And there were a couple references. To me, that sort of sounded like it was a power calculation to justify that sample size, but the authors didn't actually do a power calculation or tell us 6 dogs were likely able to detect what difference in platelet response between healthy dogs and dogs that weren't receiving medications, and then dogs that were. So I don't know exactly where the 6 came from, and if that is accurate. I would have loved to see a priori power calculation done to make sure that enough dogs were enrolled, but they did enroll 6 dogs that were mostly, I believe, from staff and student owned. The PLN dogs had to have persistent proteinuria. They didn't specifically define what persistent was, whether it was, I think many people, and I think the IRIS guidelines might say over 2 weeks, but we don't know the exact definition that was used for that. Their inclusion criteria was inactive sediment, negative culture, no concurrent disease that could cause proteinuria, and then they were excluded if they were receiving glucocorticoids or NSAIDs that could cause proteinuria or affect the platelet function, or obviously any anticoagulant therapy. And thanks to Dr. Shropshire for adding the clarification for her manuscript, saying that it came from Ben Brainerd's study and a power calculation from healthy dogs. So it seems like they just used that power calculation, which is certainly better than just ending up with 6 overall. Okay, can you guys hear me again? I know I seem to be cutting in and out a little bit. Am I back on at the moment? Okay, very, very sorry for this. I tried to find a better place in the hospital, so I apologize. So the protocol is for healthy dogs, they were going to receive clopidogrel once a day, and then the PLN dogs were either going to receive aspirin or clopidogrel, and that was dependent upon clinician's choice. That was not randomized. That might lead to some problems where if the general kind of gut feeling is that Plavix might be more effective, maybe you might choose Plavix for a dog that has a higher risk, or you're more worried about it, or they might have more severe disease than aspirin. Maybe not, that's just speculation, but certainly not having it be randomized is a flaw that we don't know what led clinicians to choose one or the other. And then the protocol is that for the healthy dogs, they came back a week later and they had their platelet aggregometry and their Plavix metabolites measured 1 and 3 hours afterwards. Some dogs had it 12 hours after. And then the PLN dogs, since they were going to be on it for a longer period of time, had analysis performed sometime between 1 and 3 hours after the pill at 1, 6, 12 weeks of therapy. And that was for the platelet aggregometry. And then the Plavix metabolites were measured somewhere between 1 and 3 hours post-pill at either 1 or the 6-week visit. So their assays, they use the multiplate for the platelet aggregometry. They're going to be using this area under the curve, and so I put an image of what one of these tracings look like, and the area under the curve is it's kind of a unitless number, but you're just measuring how much volume is being represented under this curve that's there. So if we have platelet inhibition, then there will be less aggregometry. You'll have a smaller curve, less area under the curve. Therefore, the Plavix metabolites were measured via HPLC, and it's an inactive metabolite SR26334 that was measured. And their definition of being a responder was if there was more than a 60% decrease in the area under the curve when they were using the ADP agonist for the platelet assay, or more than 30% decrease when they were using arachidonic acid at the 1 and 3 hour post-pill. So that was their definition of how you were a responder to Plavix or not. They used R for statistics. They had one-way ANOVA for repeated measures, the things that were measured 1, 6, and 12 weeks, which I thought was very appropriate, non-parametric tests, small sample size. Two-way ANOVA comparing the platelet aggregation and the metabolite concentrations between populations, and they had a appropriate p-value, so I had no problems with their statistical analysis. So getting into the results. So they had 6 healthy dogs that were enrolled, 3 were female spayed, 3 that were male neutered. They had 14 PLN dogs that were enrolled, 12 that completed the study. Of those 14 dogs, 10 of them received Clopidogrel, 3 received aspirin, 1 had aspirin, and then was put on Clopidogrel study. So the 14 were azotemic at the time of study enrollment. Most of those were IRIS stage 2, and another 6 were hypoalbuminemic, and there were 4 that were both azotemic and hypoalbuminemic at the onset. So when we're looking at the results they found, looking at the platelet aggregation, we have here on the left their baseline 1 hour and 3 hour post, and we have our healthy dogs and our PLN dogs, and we see that both populations had a significant reduction in their area under the curve at 1 hour and 3 hour, and here on the left is with the ADP agonist, and on the right is the same thing, but it's using the arachidonic acid agonist, and there was a reduction at 1 and 3 hours, but the PLN dogs did not have quite the same magnitude as those healthy dogs that were receiving Clopidogrel as well too. So looking at their definition, having more than a 60% decrease from baseline with the ADP assay and 30% reduction with the arachidonic acid assay agonist, most dogs were considered responders at one or both time points. But I believe that there was one dog that was a non-responder that had no response to either of those 2 assays. And I believe it was only 9 dogs that they had this data for. So out of the 12 dogs that completed the study and 10 being on Plavix, only 9 had the platelet aggregation that was performed. When we look at the metabolites were not different between the healthy dogs and the proteinuric dogs in any time point. And that was seen at the 1 to 3 hours, and then some of the dogs that were done at the 12 hours. This was only done in 8 of the PLN dogs. So again, we don't have even their full patient population that was having all of these testing performed, but no difference was seen. What would have been really nice to see is if there was a suspected change how many dogs will we need to enroll? I think that the study was probably significantly under powered for looking at these differences. You know, the having 8 dogs and 6 dogs and looking at different metabolite concentrations. We don't have any power calculation to say whether we had enough dogs or how many we would need to enroll in order to actually detect a difference if it was there. And Plavix is metabolized by the liver. So unlike drugs that we have to adjust their dosing in dogs with renal disease because they're not excreted normally, Plavix is not something that is routinely altered in its dose for azotemic patients. And I think we would expect the metabolism to be pretty similar in dogs that are proteinuric or not. However, there have been some phenotypes described in people where, because they have different P450 enzyme activities, they're going to have some people that are going to not metabolize Plavix well, and they're not going to respond, and they'll be drug resistant because they just have a polymorphism in their P450 enzymes. So just going to some comments before we move on, Eva suggested that should they have run a repeated measures of the NOVA on their stats? I'd have to think about that, and I couldn't say off the top of my head whether that would be the better test. It's possible that it could have been, but I will show my stats ignorance by really diving deep into that one. But I'll let any statistical person speak up and try to answer that question, whether that was the correct testing or maybe a different test should have been done. And then Hattie also wanted to point out that the IRIS staging scheme was either misused or misdescribed, and by the authors say that IRIS defined azotemia, but this is a common misconception that the border between stage 1 and 2 categorizes a patient as azotemic when the patient is supposed to be diagnosed with CKD first. Understand. So certainly we want to make sure they fulfill all the criteria of CKD before we are then staging them, rather than taking their values off of a single time point and then extrapolating it and saying that they do have CKD from there. And Dr. Shropshire responded saying that the metabolites, interesting angle in the population. The reviewer seemed to suggest that they classify them as IRIS staging versus creatinine. So very often we have to bend the knee to the reviewers if we want our manuscripts to see the light of day. And Joe concurs with Eva that likely a different statistical test probably should have been the one that could have been used. So the discussion and kind of the take-home points is that of the dogs that were tested, about 8 out of 9, so the majority were considered responders using the ADP agonist, but actually the majorities were considered non-responders using the arachidonic acid agonist. Which one is more representative of what is happening within the patient? I don't think that we really know that, and I don't think we have at all been able to look at the effect of these drugs and looking at the overall reduction in thromboembolic complications. You know, I'm not aware of any study, whether retrospective or prospective, that has looked at outcome and compared dogs with PLN who didn't receive antithrombotics and dogs that did, or many other diseases in that regard. So I think that's certainly something that we're missing, that we don't even know if this does anything or if it's associated with a better outcome overall. One point I didn't mention during their methods, but they actually ran the platelet aggregation using saline rather than another agonist. And it was found that the PLN dogs did have higher area under the curve than the healthy dogs using saline. And maybe that might suggest that these PLN dogs were did have platelet hyperaggregation, as been theorized and shown in experimental models in dogs, and certainly a common model in people as well too. They didn't see a difference in the metabolites, and I think it's great to look at that, but I think the study was probably very underpowered. If we would expect that we're looking for polymorphisms to cause a dog to not have the normal metabolite production, you know, we need a pretty decent number of dogs in order to pick up a polymorphism if it is something that is represented in a small percentage of the population, which is quite typical. So I applaud them for looking at it. I don't necessarily know if that answers the question, if there are some dogs that, despite being on clopidogrel, they might have a lack of response to it. And that's certainly been well established in people. And the authors cite a paper that showed the presence of proteinuria, and this was just a dipstick measurement of proteinuria in people, was associated with people being more likely to not respond to clopidogrel than if people did not have proteinuria. So whether there's any other interactions with the pharmacology and pharmacokinetics and dynamics of the drug, it's certainly possible, but we still don't completely understand that in dogs overall. Shelley had mentioned that manuscripts that go through JVIM, if there are 3 reviewers, then one of the reviewers is there for statistics. And Dr. Shropshire also said that a statistician did review their methods, and they were okay with it, which is certainly the best guidance we can certainly have moving forward. So are there any other discussion points or any other thoughts that people had? I did have some other critiques that I probably mentioned a couple of them, but I'll go over in the next slide, but wanted to open it up and get some ideas and some discussion here that people might be interested in sharing. Mary mentions that we need to think about the other components of Virchow's triad, that they had a dog with stage 4 and thrombi that was dehydrated and had calcifications of vessels, and all 3 components. So the vascular, endothelial damage, and blood stasis are certainly other components that we need to worry about. And the endothelial damage component is actually the reason, or the theory, that the authors found that the dogs with CKD that were only mildly proteinuric actually were found to be hypercoagulable just as frequently as their PLN dogs were. So that certainly could be a factor that could also be there that we need to consider. I think it's something that's hard to really evaluate and test for. If they have calcified vessels on radiographs, you can imagine that their vascular endothelium is a bit altered, but hard thing to look at. But certainly those other factors are very important and definitely contribute to the risk of thrombosis. Any other discussion points or any other things that people had that they wanted to discuss? Marilyn asked, maybe back to, I don't know if this is back to Mary, if why the thrombus occurs at the trifurcation. To everyone, okay. Good question. So certainly my thought, and this is just me thinking out loud, and certainly I haven't done the research or have looked into the models, but I've thought that the trifurcation was probably the place that's going to either collect clots that had started to form maybe upstream and they just lodged there because it became more narrow. There was likely more resistance at the trifurcation than the branches just coming off and going off to the side like the renal arteries. But that is certainly supposition on my part. I don't know if other people have thoughts on why we tend to see either the trifurcation of the aorta, the major iliac arteries often being plugged up by some of these thrombosis when we have aortic thromboembolic complications. Yeah, I think probably that size would lead to the turbulence and narrowing of the vessels that are there. And Joe says that he sees more in the lungs or small vessels in the kidneys and spleen. And I would agree. I think I see them in the lungs most commonly, but I also think that it's the most obvious site, that if we have a pulmonary thromboembolism, it usually causes pretty severe symptoms. And if there is a small infarct to the spleen, that maybe I'm going to catch it on ultrasound, but clinically that might have minimal symptoms. Certainly depending on the magnitude of thrombosis to the kidney, you can have dramatic reduction in GFR associated with it. But it's very tough, and I think we all recognize that to really identify how much thrombosis is present. These thrombi can start to dissolve pretty quickly after death. So even necropsy studies can be challenging to find them. So some of the critiques that I had of the study is I would have loved to seen a power calculation ahead of time to determine the sample size that they needed to evaluate for their objective. And also I would have loved to see more of a hypothesis overall as well too, that they were expecting dogs to have this change or that change, rather than just the objective of looking. But I greatly applaud them for taking this big step moving forward. It wasn't randomized, and when we get down to it, it ends up being more like a case series where we have results on 8 or 9 dogs that had PLN that were given Plavix. We really can't compare the aspirin group well, because we only had 3 dogs that went through that. There wasn't the best adherence despite those small number of dogs to the study protocol, and it's always challenging with owners to bring them in and have them come in and do everything. But having some dogs that had measurements done at 12 hours or versus the 1 to 3 hours, or dogs that just didn't have samples, as the number of dogs in the study are smaller, it becomes harder and harder to be able to draw conclusions from it. And that's kind of the same thing there. The aspirin group, I probably, if I was the reviewer, would have said, why don't we just exclude those 3 dogs from this and let's just focus on the Plavix, because I didn't think it necessarily helped anything for their main objective, and it's hard to make much out of the 3 dogs that were enrolled. And again, having a nice objective to see what they were trying to observe and if they thought there was going to be a difference. But this was more an exploratory study. So this is my last slide that I have, and this is the questions that I certainly ask all of my interns and trainees every time that we go through an article. Does this article help change our clinical practice? Are we going to be treating these PLN dogs any differently? And then how would we design this study differently if we were doing it, as well as how would we design the next study to be able to take their results and move forward with it and be able to advance our understanding more? And that kind of puts it into just the larger framework of certainly open to discuss any thoughts that people had, and comments and questions and any other points of discussion that people would like to bring up. Alice had asked, are people putting their dogs with Cushing's on Plavix? And personally, I guess I have in a couple of them that were also pretty heavily proteinuric. I don't routinely do it personally. I am also not routinely doing thromboelastography. So I guess it depends on my mood of the day, to be honest. It's not a consistent thing that I find myself doing. And she also mentions that they do a lot of thromboelastography, and we might be overestimating the risks of clotting. And I think that that's true. I mean, I haven't had access to thromboelastography at a number of places where I've been working, and I can't say I've often thought that I was missing much. And I often had thought, when you look at TEGs, you're probably going to have something that's going to be abnormal. It's, in my experience, having them now and being able to do them, it's very frequent that at least one of the 5 or 6 variables you're looking at is probably going to be abnormal. And what does that mean? Does the long R time is that the most significant factor? Is the maximum amplitude the most significant factor? Is the global picture? It's probably a bit challenging to know for sure. I don't do that test very frequently at all because I don't have good correlation between outcomes. So it could just be another test that could tell me I should do thromboprophylaxis. I probably didn't need a test to tell me that either. Jess had mentioned it would be interesting to see whether there's effect on platelets in those dogs that require immunosuppression, or dogs that are Cushing's due to medications that could affect it. And certainly there was a very recent paper, I think it was this morning, that officially the JVIM came out, looking at dogs with pred and Plavix, and looked at platelet function testing on that, and very interesting results that were there. I think most of us tend not to use steroids for treating PLNs that are immune complex mediated because we're worried about the hypercoagulability that's there. But I usually do a short course personally. I usually do about 2 weeks as I'm waiting for my mycophenolate to kick in, and then I start tapering it. That's my probably go-to protocol for most patients with immune complex GN. Some people bring up rivaroxaban, and certainly there's I think a couple small case series of like 4 dogs here, or maybe another few dogs of an oral, I believe it's a factor 10 inhibitor, which is, I think, another interesting choice. But I guess like one question is this a disease where the thromboembolic complications are mostly driven by the platelet hyperreactivity? Is it the coagulation cascade? Is it both? And it's probably a bit of both, I would imagine. So I don't know if since these dogs are found to have both venous and arterial clots, it might not be quite as easy to say these dogs definitely need an antiplatelet drug versus an anticoagulant drug. And I don't think we have any evidence at all to suggest that one of those is better than another in dogs with PLN. Certainly we have Plavix being superior to aspirin for cats with arterial thrombi, but most of those cats have underlying cardiac disease and not PLN. So I think it's another thing that is an unknown that I hope this will be able to help propel things forward. So lots of really good comments and discussions here, and we could certainly keep going for hopefully a very long time. It was great to see about 80 people show up to these rounds. It was fantastic. I will start to just bring them to a close just to respect everybody's time. Again, I really appreciate everybody coming to these. I thought this was fantastic, and hopefully this will continue to be something we'll do every other week. Thank you to Dr. Shropshire as well too for attending and participating with her manuscript being published. Really thank you for that work that you did. I think it was excellent and really helpful. Please tune in for the next journal clubs in 2 weeks. Ewan will be presenting retrospective analysis of diagnoses and outcomes of 45 cats with micturition disorders, presenting as urinary incontinence, which is pretty awesome. Check out information at asvnu.org if you'd like to join. And we're certainly looking for presenters. We're hoping to have a different person or team of people present every session. So please shoot me an email if you're interested in presenting at Journal Club. I'd love to make this really interactive and encourage everybody from the community to participate. I hope this was worthwhile and the audio wasn't too terrible, and really appreciate everybody coming and look forward to speaking with you soon. So thanks a lot.